because we know that sometimes that's my downfall. Forget.
Hi, Christine.
See Miranda coming in.
Good to see you. Miranda, great.
Hello, everyone.
Hey, Miranda.
I'll join in video in just a moment.
Emily, I don't have anyone else in the waiting room, so if you want to go ahead and get started, I've got 3 out of 5 of you, so it looks like you have a quorum today.
Yeah, I was actually counting, I think 7 TAC members now. Am I right? Not that I don't want a quorum, but we have 2 unfilled seats at this point. Do we count those or not count them?
You would still need to count this. So who is no longer with us? Do I not have an updated list?
Our Frisky representative, the family resource worker, she had taken a new position, and I'm waiting on the coalition to appoint someone else. And then we're still waiting on KAYAK, the Kentucky Association for Community Health Workers, to appoint someone. I just put it on my calendar again for next week to follow up. For some reason, I just haven't had much luck. Did you ever end up reaching out to them?
I'm going to be honest with you. I've reached out to a few different associations for a few different TACs, and
Yeah.
I'm not getting a response from any of them. So I know it's been very busy, and they're probably also still looking for Charlie's name. So it's not from a lack of trying always. And so, but I believe if you have 5 seated members and 2 vacant, that you have 5 members, 3 of the 5 would quorum. So if there's someone who's been doing this longer than I have, and that is incorrect, please speak now or forever hold your peace.
Well, we'll say that we have a quorum, 3 of 5 members. And thank you all for joining us today. Good to see Christine and Miranda on. And Erin, just let me know if Patty or Arthur join us in a few minutes.
Yes, ma'am.
Our first item on the agenda is approval of minutes from our last meeting. Have you all had a chance to look over those? Any changes or any questions?
Look good to me. I move to approve the minutes from the April meeting.
Thank you. Can I get a second?
I'll second it.
Thanks, Christine. All in favor say aye.
Aye.
All opposed, nay. Motion carries. Thank you all. And then we'll move on to old business. So these are items that we've covered at previous meetings. And we'd just like to know the status of the following items. So the first here is the emergency Medicaid cases that were pending review. These were cases that Miranda had brought to Medicaid's attention a few months ago. Miranda, do you have any update there? Or are we just looking for the cabinet to tell us if anything changed?
Oh my goodness.
It looks like Lee Geis is on here too, so.
Yeah, Miranda sent all those, she sent me a couple of cases, and excuse me, I confirmed that it was just a matter of a timing issue about when those the manual process had to take place to extend them for the PHE, not extend them for the emergency Medicaid, but just extend them. And none of them, the notice got sent, yes, but all of them were approved and extended. Do you have anything else, Miranda? Did I not respond to you on those? Anything can happen.
No, I really appreciated you responding quickly on the last one, which had been discontinued, but now you fixed, I think you fixed it. So currently, I don't think I have any emergency Medicaid cases that are pending that shouldn't be currently.
Okay, great. It's the reason that some of these cases were pending, has that also been cleared up? Or could it still happen to others?
It-
Question,
Go ahead.
sorry.
Oh, Lee, I was asking if the reason that these cases were pending to begin with, if that's been cleared up, or if this could potentially still happen to some.
No, it could potentially still happen.
Okay,
Okay.
and is there anything being done to change that, or is that part of the bigger?
It's
Reason
part
for-
of the bigger overarching
Okay.
maintenance of coverage, the maintenance of effort, the coverage, continuous coverage requirement, whatever, whichever phrasing you want to use for the public health emergency. The time limited emergency Medicaid cases are part of a group of cases that get extended periodically as we roll through the public health emergency. And they get extended by running, it's a manual batch. So someone actually has to go in there and press a button. And sometimes if that button doesn't get pressed before some of the other automatic triggers are triggered, then it turns out it gives us the wrong result. But and so, but say, let's say that somebody gets missed, they'll get picked up again. And if we hear about it, we can fix it.
So something that Medicaid is now more aware of and keeping a close eye on, sounds like.
I could tell you that on January 1st, or thereabouts in 2023, the overall change in emergency Medicaid should be implemented, and we
Did you-
shouldn't run into this issue again.
So you said January 2023?
Uh-huh.
Great.
That's awesome. One of the issues I had was that I had called DCBS about some of these cases. I'm thinking of the last one in particular when it had been terminated, but I knew it shouldn't have been because of the maintenance of effort. And the DCBS workers didn't think the maintenance of effort applied. So I kind of argued with them before emailing you. Yeah, that's the challenge, and when they don't know about the program.
I sent that message. You told me that, Miranda, and I sent that message to DCBS Central office so that they could send out some information on that.
Okay, thank you.
That's the most important part that we hear too. I mean, it's probably not the most important, but it is important to hear when folks in the field aren't aware of what's going on. So when that happens, we can send messages from the central office. That doesn't mean that by next week they won't forget, or someone else on the other side of the state doesn't have the same thought, but it gives us an opportunity to try.
Sure, thank you.
Well, thanks for that update, Lee, and it's great to hear that some more like overarching changes are going to be made to emergency Medicaid for next year. The next item that we have here is DMS. This is our recommendation to DMS about disseminating the flyer that Kentucky Equal Justice Center created about presumptive eligibility and emergency time limited Medicaid. Just wanted to see where y'all were at with that.
Emily, did you say this was the MAC recommendation you guys made?
It was a recommendation. It's also been something we've requested in the past, yes.
I have gotten all the MAC recommendations. I'm just waiting on their approval. and then I'll have that out to you. But I don't have that answer sitting right in front of me. I apologize.
That's okay. So that's something that you'll follow up with us on.
Yes, ma'am.
Okay, thank you. And then the next item here is the Medicaid and K-CHIP eligibility diagram. I may have missed it because I know that Lee shared that with us last meeting. We had asked about, you know, the federal poverty level diagram or that table to be added to it. I'm not sure if there was anything else that needed to be done to finalize it. So if you could just jog my memory.
Well, right now I'm trying to jog my own memory. Did I send you the diagram that we finished? The listing about what the eligibility categories? Okay. And
I
you
don't
just-
remember. Oh, you did see it, Miranda? Did you just shake your head? Yes.
Yeah.
I saw it on the screen. I don't remember receiving it in email, but I might have missed it then. So I'm sorry if I did. Christine, did you receive that?
I don't remember. I know several things came in. I'll do a quick search.
If it's something I sent, I can always resend it as well.
Yeah, Erin, that might be helpful. It's the eligibility diagram, and we had just asked that the FLP chart, you know, sort of table be added to it. But I think aside from that, it looked really good, and we were excited to have it so that we could share with folks.
I just responded to the original email thread.
Okay.
And I think this is what we're talking about, Scott, the program, the different types of Medicaid and the description for each one.
Yes, with like the income eligibility and other things. Arthur is asking for a link, so I'm going to send that to him really quickly.
Okay, that's not it. That's not it.
Oh,
Okay,
the assessment is not it.
that's one thing, but that's not the document. You're gonna have to let me look for it and find it.
Yeah, I recall Lee showed us something really good.
Yeah.
I don't
Well,
think we,
We've all seen it. I think we
Okay.
just might not have the actual document.
It's entirely likely that I blinked in between the time I showed it to you and the time I was supposed to hit send and didn't. So I apologize for that. But let me find it while we talk.
Yeah, that sounds great. Thanks. We'll just move on with the agenda here. The next item that we have, this has come up a lot, the decision about lifting the 5-year bar on covering legally residing pregnant women. I believe at our last meeting, DMS was close to having a decision.
It's done. It's
Has-
done.
It's been lifted.
It's done.
Okay, thank you.
Systematically, we're still not quite there, but we're doing our very best to pay attention, and when somebody comes in, that we're able to move forward. Well, it's not effective until 7/1. I apologize.
So on 7/1, does someone who would be applying who is legally residing pregnant, but you know, within that 5-year time period, would they be able to complete the application online, or would they have to talk to a DCBS worker? Is there, you said it's not systematic, so I just wanted to make sure I understood how the process would work.
They're gonna need to talk to somebody.
Okay. could it be one of the frontline DCBS workers on the phone or in the office, or does it have to go above that?
Well, I'd say this, okay? And I'm not trying to be flippant with this answer, but if they get a responsive no with the frontline worker, they need to ask to send it up to the main office.
Okay. And
Okay,
then last question, connectors, will they be able to do this? Or will they have to also elevate it to another level?
I'll have to talk to the SBE folks, the HBE folks, and see how they want to handle it. I just know that we've got some approval, and we're doing our best to get the systematic implementation in place.
Great.
So if if somebody runs across a person, a pregnant person in this category, and they're having issues, you can always call your DCBS partners, people that you work with closely,
Okay.
and they
That's
should
good.
be able to work around it until the system is done.
So
Wow, that's great news.
when Lee,
Uh-huh.
when you just mentioned that, is that something, the notice that goes out to the connectors? Also, what you just expressed to us, if anyone runs into that, do the connectors get updated the same way too somehow, whether it's a notice or email to them?
I do not know how the connectors get notified. That was what I was trying to say, Christine, before, is that what I'll do is I'll talk to like Malia or David, and they will in turn reach out to the connectors.
Okay, great. Because you
Okay.
said it's effective July 1st, which is coming up real soon, but the system is being worked through to manage it, right?
Yes.
Okay. Thank you.
Right, normally we do receive those types, as connectors, we receive those types of updates from Kentucky Health Benefit Exchange, but I haven't seen anything come out yet, so.
Well, this is pretty new.
Well, this is great news, so thank you. We're very happy to hear it. Do you have an idea, Lee, of how many people will qualify as being, in this particular category?
I do not.
No.
I do not. We didn't have a methodology to, we can talk about how many pregnancies we cover and how many births there are in the state, but we have no way of knowing who's been in the state less than 5 years.
Right.
Okay.
Yeah, that makes some sense. I'm assuming some of these people were covered under presumptive eligibility, but of course, you want to have enough information to be able to suss all that apart. Any other questions before we move on? That's just very exciting news, so we appreciate it. The next item we have here, I've lost my place. Okay. The network adequacy one pager or decision tree that we discussed. Arthur, it's good to see you on here.
He said he wants to apologize
Oh,
for being late. And he has about a page and a half to read.
Okay. Well, we're glad you could join us, Arthur. Is that related to, is that something that we would consider new business? I do have under new business, the item that you had asked for me to add, which is
No.
spending some of the FMAP funds on onboarding PDS employees. Okay, so we'll get to that after we cover our old business. And so far, we've covered the first 5 items under old business. Well, we're on the letter E, which is developing a network adequacy one-pager decision tree.
Okay, Angie Parker here, the EMS. I have a one-pager in draft that I will share with Aaron to share with you to look over to see if this is what you were expecting.
That's great. Thank you for your work on that. I know last time we met, you had been talking with each MCO and about their process. Did you find that the process is fairly similar among MCOs? Yeah.
Yes, I mean, it's basically, if you can't get it, is to contact the member services department. But I will say with this network adequacy one pager, it does illustrate you need to utilize your primary care doctor. They should be your first line of defense and trying to find an appropriate provider when it's needed. Now,
And-
yes, so that's what this one pager is going to allude to as well. But
Well, I'm all for having a good primary care provider to help you with care coordination. So one other question, I know that one of the concerns that we had was just related to what happens when you go through the process, you contact member services, but they kind of put it on you to call around and, ask for appointments, but then I don't think that it's always clear how you can get out of network care covered at that point. If
that's
you're not
addressed
able-
as well. It
That's
depends
addressed.
on the situation. That's addressed in the one pager kind of as well. Just look it over, and if there's any questions after that, but there is a disenrollment for cause process as well. That,
Okay, right, if you need to change your MCO.
but
Okay, well,
if
thank you
there's
for working-
issues, I mean, if the member goes through all this and there's still issues, feel free to reach out to me or anyone else on the MCO contract team.
Yeah, I think that is sometimes what happens, is that people are kind of discouraged or don't know their right to keep, moving up a chain. When you go to member services, you're still talking to that MCO, and if that MCO is not kind of holding up their end, then I don't think most people know to go above them.
If they're talking to member services and they're not getting anywhere, ask for a supervisor. I mean, I didn't put this in this one pager, but there are ways that you can continue to hopefully work within the MCO, but each person's first line of defense is their primary care doctor.
Okay. All right, well, we'll take a look and get back to you with any feedback.
Okay.
Thanks. Any questions about that before we move on? Okay. The next item we have here is the health disparity and equity TAC. Is there any update there? I know that last time we talked, you were all waiting on, I think, one additional member.
So this is
Hi.
Leslie. Oh, I'm sorry. Is somebody else speaking?
Yeah, it's Veronica.
Oh,
I'm
okay.
here. Hi.
I wasn't sure if you were on.
Thank you. I apologize for being late. When meetings are on top of each other. Veronica Cecil with Medicaid. We are excited to announce that the governor has approved all of the appointments. We're now just waiting for that official piece of paper to go out so that we can start contacting the new members and getting meetings set up. So we very excited of the progress that's been made, and want to thank everyone again, including some folks on the TAC who provided us some recommendations. I think it's going to be just an amazing opportunity for definitely us in Medicaid to really focus on equity and disparities, and what can we do with our policies and our program to create better access.
This is more great news, so thank you. Yeah, we'll look forward to seeing the announcement and whatever schedule of meetings that you all put out. Any questions there?
Oh, thank you, Veronica.
Yeah, thank you very much for continuing to work on that and kind of chip away at getting everybody in place. Our next item is the stakeholder meetings that we've heard you're going to hold in terms of planning for the end of the public health emergency.
Yeah, so, right, so we did not get the 60-day notice, which means that the July date will be pushed. We expect another 90 days. They've been doing it 90 days at a time. That puts us through mid-October. And, you know, of course, all we can do is speculate, but we anticipate a likely another extension. But we have, as a result, we haven't taken our foot off the gas, but we've certainly released some of the pressure on it. So we're probably looking more in sometime next month with engaging stakeholders.
Okay, thanks for the update. And will those just be relatively open meetings, or are you gonna? Yeah, okay.
No, we will want to do, there'll probably be some direct engagement, but in general, we'll have public meetings that we can get feedback from all the different stakeholder groups.
Yeah, that sounds great. Thanks. Our next item here is reimbursement for transportation assistance for the 1915C waivers. I think this is really just wanting to know the status, how it's working.
Yeah, so right now, our only option is it is reimbursable through some of the services. So, for example, attendant care, and some of the other waiver services, transportation is included in that service. So the provider, so you can have an employee or your provider can provide transportation as part of the service. We are looking at, as we're completing the rate study, making the transportation service available for across more of the waivers, as right now transportation alone is only available in SCL. So we are looking at expanding that as part of the rate study.
All right, thanks.
Which
And
leads right into the next, item.
Exactly. Any updates there?
So we are progressing forward with the rate study work group. We have our next big meeting on June 27th, and we are now starting to do some of the wage analysis. And I've preliminarily looked at some of the information, but this is where we're getting into the meat of the information, looking at the survey responses, looking at other states, looking at the Bureau of Labor Statistics data. So that will be Monday, the 27th will be our first meeting where we actually really start getting into the data and talking about some of the responses. We will post those like we have been, the recording of the meeting and all the materials after the meeting. I think Kelly usually has them up before the end of the week. So before the first, that meeting should be posted that we have on Monday, but we are continuing to work very diligently on rate study.
Great, thank you for those updates. The next is also probably related. I know that, well, not necessarily to the rate study as much as that additional funding for HCBS services.
Right.
And the feedback.
So the feedback sessions and the stakeholder groups are on pause right now, as we are in the process of, we're having to modify our approved spending plan and all the activities that were previously approved in that to change it to the 10% increase that was included in the approved budget that we were directed to fund using the ARPA funds. So that essentially will take the money that was allotted to those other activities. It will deplete those ARPA funds. So, we are stepping back right now, looking at what approach can we take? How can we still do these important activities? So there'll be more to come about that. I don't have a very good update about that right now. We do realize how important stakeholder engagement is. And I am looking at this fall having a kind of our road show around the state where we have the sessions in person. again, to try to talk about, what's going on with waiver and to hear from stakeholders. And so more to come about that, but I'm excited about finally being able to do some in-person sessions again, since it's been a long time since we've been able to do that.
Yeah, I think that makes a big difference for people.
Mhm.
So I know you mentioned that this ARPA funding would be really mainly taken up by this 10% rate increase. Is that something that you've gotten CMS to, I don't, approve is probably.
So, well, no, they have to approve it. And so we've had some initial conversations with them, and indications are that it will be approved, but we still have to complete the final step of sending them, the amended spending plan, which will be done this week. We're in the process of doing the final edits on that. And so we're in the process of finalizing that this week, and then we'll communicate as that gets, as we know more, and how things are going to happen. Then we'll have more. We'll either record a session likely, or we'll have a live, some of those like live question and answer webinars that we've done. We'll do something similar to that, to let people come in and ask questions.
Okay.
Yeah, just to add to that, Emily, we did convey our concerns about the consequences of utilizing the ARPA funds for this, because it will take away funds we put aside to do a whole bunch of really great things that we wouldn't normally probably have in our budget to do. And so now we're having to scramble a little bit to see, well, what can we then do under our regular budget for some of these activities. And, it's regrettable, I think, that we're having to make those decisions, but it's unfortunately the reality that we're in.
Yeah, no, I know that's not ideal. And a lot of us have concerns about those programs that aren't going to get the additional funding. One thing that I think I heard, I don't remember if I saw it as an email update or in another meeting, but the PACE program that was to be created and receive some funding. Is that still going forward?
Actually, PACE was some of the funding for PACE that had been set aside in the spending plan was really for the project management and the some of the initial implementation activities. And we, Lee and her group did such a good job with it. We were beyond, by the time we got the approval on the ARPA spending plan, they were already advanced beyond that. So PACE is separate from that, and it is still continuing.
That's good news. So can you tell us a little bit about what PACE, who will be served, and about how many people you think will be served?
I will is Lee still on?
Yes, still here.
I will ask Lee if she can give that update, because she knows much more about it than I do at this point.
Just let me get myself over there where you can see me. I know it's much better if I can. I can't move you across there. Just give me 1 second. There we go. Nope. Okay. Just all about screen setup. So PACE. We will have the first two PACE organizations will begin hopefully supplying, but enrolling members and providing services maybe August. This year, there are a lot of moving parts, and so everybody's desperately trying to get ready and are hopeful right now for August, but we've already moved that target date a few times. So that's why it's not set in stone just yet. The two providers will serve two different areas of the state. One, Bluegrass will provide in Fayette and surrounding counties. You can go onto our website and see the map to show. And the other provider, Horizon Healthcare, actually has we'll have three different centers and three different sites. One in Bowling Green, one in Richmond, and I think the other one is in the Somerset area. I'm not sure if it's actually in Pulaski County, but it's in that area. It might be in Washington County. Each center, usually, so I'm talking now policy discussions way up here, but financial folks and other PACE centers around the country talk about that PACE centers usually serve about 200 enrolled members at a time. So they'll have to, of course, ramp up, but that's usually about their maximum. The criteria for that would be you're going to be 55 or older, and you have to meet a nursing home level of care. And that's the criteria. So you can be Medicaid eligible, dual eligible, and they will also have private pay.
Any questions about that? Thanks for those updates. And I'm assuming there'll be some announcement that goes out about that program too, once it gets
Yes.
starting. Okay. Any questions about that?
Is there a site or a link where I can get just an overall description of what the program is?
Honestly, we don't have that posted, but if I were you and you want an overall description, I would Google it and see if you can find the PACE Association page. Or I can find it and throw it in the chat for you in a minute. They have a really good overview of what the program is. And it's basically, so you've got bricks and mortar, they've got to have a center. And once you're enrolled with PACE, the PACE provider is responsible for all of your health care, some social needs, nutrition, transportation, prescriptions, everything. So it should be, I think of it kind of like my grandmother many years ago used to go to the Senior Citizen Center in Lexington, and she would have, some social time and get to be around some folks her age, and they would play cards. And if they needed a doctor, there might be a doctor or social worker around. So in PACE, they'll have that opportunity. They can get meals there. They can do a lot of things, but there also be an interdisciplinary team made up of several different kinds of providers, and the family members or community support members with the enrolled member who will come up with a plan of care. And the whole point is to keep folks out of institutions and out of hospitalizations and let them age in place.
This sounds really good, Lee. I know it's right in line with AARP's age friendly. And so if there's any, if you're needing any help or sponsorship, I think they'd be interested in supporting.
Excellent. Excellent. Thank you. We've worked for quite some time to get this close, and so we're very excited about this implementation in Medicaid as well.
And there's such a gap, right, from Medicare, which becomes effective 65. And a lot of people, for different reasons, that age 55, between 55 and 65 is such a hard age to get coverage, So yeah, I'm going to investigate it. Sounds really good.
Excellent. Well, I do recommend the association's page, and like I said, I will find it because it's in my history, and I'll throw it in the chat for you.
Thank you, Lee.
Well, and Lee, if it's not too premature and there's information that we can share, kind of late summer, early fall, Kentucky Voices for Health and a number of other organizations are going to be doing a lot of education. AARP is actually going to be sponsoring it. So it seems like we're going to be doing regional education where we just give people updates about these programs. So if there's something that you just want to pull together a few facts that we can share, we're happy to try to get the word out.
Great. I will let our communications folks know that, and maybe they can put something together for you.
Sounds good. Thanks.
Mhm.
Anything else before we move on? I think we should probably do the updates on the maternal health review and the Medicaid reimbursement for licensed certified professional midwives together. I shouldn't have put that quality strategy project in the middle. Any updates there?
No, unfortunately, Dr. Terrio couldn't be here today, and she's she's been doing the kind of deep dive into maternal health for us. So I don't have any update today.
Okay. Thanks. And then the Kentucky Medicaid Quality Strategy Review Project.
It is continuing. We expect it to go to public comment by August, hopefully. So it's been a process. We're getting there though.
So the public comment, will that be a typical like 30-day public comment period?
Yes.
Okay, great. Thanks. All right. Any other questions before we move on? So, oh, I'm sorry. Yes, Christine. Hi.
Trying to find my mute button. How is that the Kentucky Medicaid Quality Strategy Project? How is that different from what is the other one? The other TAC, health disparity and equity TAC. Those are not similar, right? Those are two different.
Yes. It's the Medicaid managed care quality strategy that we're working on. I'm not familiar with the health disparity, what the health disparity acts strategy, quality strategy is. So it appears Senior Deputy Commissioner Veronica Cecil may be able to answer that part.
Right. Once a technical advisory committee, the strategy is something that's required by CMS that we're just going through and following the steps so that we can get it submitted.
Thank you.
Moving on to new business, we have a few items here. And the first is a question we always ask, but I figure we always get updated information. So I put it under new business. How many Kentuckians are currently covered under traditional versus expanded Medicaid, as well as presumptive eligibility?
So presumptive eligibility, we're right at the 1,700 mark right now. And make sure I open the right report. We have 1,651,000 and change members. And they are broken up. Of course, I open the one that doesn't break them up into coming. Expansion members are 611,000. Okay, so
Yep.
A little over 1 million are not expansion.
Got it. Thank you. That's always good to know. And then a question that I think we asked but skipped last meeting, which is how many Kentuckians were covered under presumptive eligibility Medicaid in February of 2020, so right before the pandemic, or what was the average per month in 2019?
So, I saw that on the agenda. I thought I had sent that to you, but I have not been unable to find it. So,
I think that Aaron sent out some information in an email, but maybe there wasn't the context that we needed. I don't remember either, Lee. I'm sorry.
I remember that you sent a chart that answered another question we had about
Okay,
how were people enrolling in PE? Was it connected?
right.
There you go. It was related, but different.
Okay, all right. I'm gonna actually have to get a data pool on this.
Okay.
I apologize that I let it slip off my radar.
Do you need anything else to get that data request, or is this?
What I can tell you is this, I can give you this anecdotally and we'll see if the numbers hold up. But anecdotally, we were running about, at any one point in time, about 10,000. Well, no, about 10,000 a year. We would have PE folks in and out. So over a 12-month period, we would have a total of about 10,000 since the qualified entities, that portion of the PE came into being. That was in 2014, that caused a big surge in just regular presumptive eligibility because we didn't have it for expansion members before or adults, except for pregnant women. So about 10,000 per year. And sometimes, and that under non-public health emergency times, you only get one PE period per year, per calendar year, or per pregnancy if you're a pregnant woman. So I'll pull these numbers and see, get them back to you. Sorry about that.
That's really helpful. Thanks. Well, and still related to PE, because I know with House Bill 7, the state will no longer be a determining agency. I don't know if that's the right term, but won't be able to process those eligibility determinations themselves. It will be hospitals, I'm assuming still federally qualified health centers and some local health departments.
So interestingly, the concept of a qualified entity that's how hospitals came into the presumptive eligibility business. And only hospitals are designated in the regulations as qualified entities. And they have to be enrolled in Medicaid and they have to receive training. So there's some other criteria, but only hospitals can be qualified entities. Prior to that expansion of PE, the folks who could assess presumptive eligibility were for pregnant women. And so they would be FQHCs, RHCs, clinics, OB/GYN clinics, or even offices if they chose to engage in that. The local health departments, I know that they were very much involved in the breast and cervical cancer treatment program, PE, because they were involved in the Kentucky Women's Cancer Screening Program. It was my understanding that as public health departments moved away from direct services, that the Department of Public Health has contracted more with FQHCs and RHCs to provide that service. So I'm not real sure about the local health departments.
That's helpful. Yeah, so that historically some health departments did do some PE applications, but you don't think that that's happening currently. And then as far as this concept of qualified entity, if hospitals are the only ones that are qualified entities in current regulation, does that mean that under House Bill 7, only hospitals can do PE moving forward and federally qualified health centers and others can no longer do it?
Oh, okay. Pregnancy PE
Is separate.
is completely separate. Has nothing to do with qualified entities can do either. Okay, but it is completely separate. So FQHCs and RHCs can still do pregnancy PE, but they cannot be qualified entities.
How is the qualified entity category, is that determined by CMS or is that state? Like, could that change in regulation?
It is federal
It
regulation.
is federal regulation. Okay.
Yeah.
Thank you. That's been particularly confusing, and I know that people have heard there have been changes to PE. So what it sounds like is hospitals will continue, FQHCs and some other providers can continue with pregnancy related PE. The application that's on the state website is going to go away in July. Is that right?
Yep. So I'm putting the citation for the federal reg into
Thank you.
chat. That is, the title is presumptive eligibility determined by hospitals.
Great. Any other questions about that before we move on? Okay. So then the last item that we have under new business is the status of DMS of the Medicaid proposal, proposed, I think I should say proposed spending. I'm not reading this very well. A
I've
portion
got
of
it.
that
So it
fund
was
is
the,
for
yeah,
onboarding
onboarding
costs.
cost, yeah.
Sorry, I think I made some typos in there.
I still understood it, so. This is caught up in part of the kind of what we're doing, the reorganization that we're doing around that and kind of our step back at what was included in the first ARPA plan and how we can potentially still move forward with some of those initiatives. So this one is high on the list because it is most certainly needed, and it is an expectation of CMS as well that participants not be responsible for the onboarding cost if they choose to have PDS employees. So.
He said, can you make a statement?
Yes.
Okay. He said, I have asked to be given time to speak today about the cabinet and DMS draft plan to use a portion of the federal medical assistance percentage funds to cover the cost of onboarding PD's employees. He said, I wrote a document, but after I thought about it, a 4-page. Yeah. A 4-page document, and he wanted to know I thought about it. He probably went and be given enough time to read all of it, so he edited down to a page and a half. But he wanted to know, Miss Emily, can he send you the 4-page document and you send it to everyone in the meeting?
Yes, I'll be happy to share it with everyone, or Arthur, you can send it to the email that we've circulated for the agenda, however you want to do it. But you're also, if you'd like to make your statement as well in the meeting.
Yeah, I love it. In Director Pam Smith's memo dated October 4th, 2021, it was the intention of the cabinet and DMS using part of the FMAP funds as a short-term solution to cover onboarding costs for PDS employees, which participants have identified a barrier to using PDS included in the rate developed for and he go on saying, since October 4th, 2021, we have heard that the cabinet and the DMS has put on hold using some of the FMAP funds to cover onboarding costs for employees, possibly until the rate study for waivers is completed, which participants have identified as a barrier to using PDS. He says, why is it so important that the cabinet and DMS use a portion of FMAP funds to cover onboarding costs for PDS employees? Keep going? He says, here I am going to use myself as an example of what the home and community-based service means for the survival of persons with form of moderate to severe disabilities. He said, about 18 to 20 years ago, I got on one of these medical waivers. My waiver is called 1915 Medicaid waiver. Okay, which includes the home and community-based waiver. In this waiver, there are several home and community-based services and supports for persons with from moderate to severe disabilities to live, survive, and prosper out in the community. He said, I received services from the part of the home and community-based waiver called the PDS. PDS allows persons with severe disabilities up to 40 hours a week of personal assistance. When I got on PDS program, I fought really hard with the Medicaid and the cabinet to let me pay my personal assistant at least $14 an hour for several reasons, such as handling or dealing with my speech impairment and other duties that I needed to be performed. They are not easy work to be done. He says, you can imagine after a person works with me 8 hours a day, weeks and months on in handling and dealing with my speech impairment, you can think how wearing on a person who are assisting me. In 2005, Medicaid and the cabinet let me pay my personal assistant $14 an hour until the Medicaid and the cabinet rewrote a new Medicaid waiver in 2015. He says Medicaid and the cabinet began to rewrite new policies and regulations for new Medicaid waiver in 2013. Said I found out that the new waiver contains several negative aspects to it. Number one, I pay my $8.14 an hour. The new waiver is going to put a cap on hourly wage of $11 an hour. Number two, we the consumer will have to pay for every background check on every aid we have. We also have to pay out of our pocket for CPR, first aid training, a 5-panel drug screen testing, and also pay out of pocket for the TB testing. He says requiring participants of directed service to pay out of their pockets for these tests and background checks puts a severe limit on who can and who cannot afford to participate in the PDS program, especially if you consider that the most, if not all participants in PDS survive on either SSI or on SSI or SSDI. He says people who are on SSI only $830 a month to live on. So if we had the pockets annually, you would cost if a person has 3 or 4 aides. The PDS program empowers and increases the independence of the individuals with disabilities, and these expenses strip away with this empowerment and independence from the people with disabilities. So from all of the above, my question is the cabinet and DMS going to use a portion of the FMAP to pay for the onboarding costs of the PDS employees, or is it on hold? And what is the status of the PDS employee pay increase?
Okay, so let me kind of step back into some of that. I completely understand, Arthur, where you're coming from on the background checks and the TB skin test and the training. So a couple things that we're doing for options there is, as we're rewriting the waivers, is to allow you as the employee to be able to determine what trainings you want for your employees and what, if you want them to have a drug screen, or if you're okay with them not having a drug screen. So we're going to have a little more flexibility in the you as the employer being able to decide what types of trainings you want your staff to have, because it may be that you want them to have some specialized training with your speech. For example, I know your attendants are great in being able to, they work with you very well, but it may be that there's a training you want them to participate in related to that, or there's something else that's important to you. So we're looking at flexibility for that. So I'm having to, as I mentioned earlier, with the ARPA funds and what we're having to go back and, we're rewriting that spending plan. However, this is still top of mind, and we are looking for ways to still be able to do this, partially through Appendix K until the rate study is completed. And then when the rate study is completed, we are looking at that cost being part of the financial management agency's costs, since they are the ones that pay the employees and do all of those, the paychecks and the any taxes, they handle all of that. So we're looking at including that money in those rates, so that it would be just like any other provider, a traditional agency. You would have an agency paying those costs and not the participant. So I know it's not moving as fast as you would like it to. Honestly, it's not moving as fast as I would like it to, or that I want it to. But we're working very hard to make the changes. Now, as far as the rate increasing it to the $6 a unit, that has been in place since March. So let me know if your agency, if you have asked them to modify your plan of care and they have not done that, because that is already available to you and has been now for about 3 months.
He said, may I ask you something?
Yes, absolutely.
Is Kipton? Or is P and is Kipta in the cabinet or the cabinet? Supposed to rewrite your budget. Is Kipta or the cabinet supposed to rewrite his budget? If he hired someone and wanted to pay them around 18 an hour.
Yeah, so
who's supposed to change his budget?
KIPTA should be doing that. KIPTA should be making that modification to your plan of care, and then they would, whichever employee, so if it's your employees you have now that you wanted to have an increase in rate, or if you wanted to hire somebody new, they are responsible for helping with that paperwork and to do the the employee contracts, where it outlines what the pay rate is for the employee, and the doing the modification to the plan of care that would allow you to pay that higher rate. If you are having problems with that, I put my email in the chat. Arthur, if you'll email me who your case manager is, I'll look into what's going on.
He said, may he ask? If what? Oh, if Camille is. Camille or.
I'm on here, Arthur. I'm actually, I'm homesick.
Or Bill? Want to make a comment or say something or ask something? Does
Okay.
Camille or Bill want to make a comment or ask something?
Can you hear me? Okay. Well, again, I've been asleep most of the day. I'm in isolation and have COVID, so you have to bear with me. I've only been on for a little bit, but Pam, I think, and again, I'm not real clear, but I think we had maybe reached out, but we have heard from a couple of complaints on the areas where they're not increasing the $6 rate for the quarter for PDS until their restart date. And I believe we have reached out. So I will clarify that and we will email you.
Yeah, I do know Bill and I had a discussion about one individual in particular, I think, and maybe he sent me a second one that I hadn't looked into more. But yeah, if you all will send me those, and then we can look through them, because what we had told them is we did give the ads some flexibility in doing the modifications because it takes getting the team meetings up. But we said if someone had just had their research or it was many months away, they shouldn't be forced to wait that entire time. So if you all will get with me again and we can talk through and identify if there's any particular pattern of area that it's happening in. I know that one, I believe Bill, was Western Kentucky, I think was where the one that we were talking about was in, like, the Penny Raw district.
And
So-
then the other comment in general is just, we were very hopeful for a lot of the FMAP money to be used as quickly as possible to relieve a lot of the crisis that we're having in staffing and waiver providers, including HCB, STL, Michelle P, and ABI. And PNA is urging the cabinet to looking at using those now in any way they can, because we're seeing it's very concerning. I haven't looked at it in the past week or two, but I can tell you that the 202Bs, which is the involuntary process for a person with intellectual and developmental disability to be placed into an ICFID facility, the number of those petitions have doubled, and we've already reached, of those petitions that have been upheld, we've already met the number we met for the entire last year. And I'm talking in calendar years. And so we think that is a direct result of the crisis in staffing. And so we really believe that this AFMAP money can be used to help with that. So we urge the cabinet to look at that using those funds now. So that's
So I agree with you. I think all of us do. And so we did put something in Appendix K that allowed for a 50% increase. The providers have to complete an attestation, because as part of that increase, they are required to pass through 85% of that increase to the direct care worker themselves. And so if you want to set up a meeting, Camille, when you feel better, please rest and take care of yourself. But if you all want to set up a meeting, I'm looking, we're also evaluating the critical incident reports and looking at what is happening. And then as soon as CMS approves the revised spending plan, then there'll be that 10% additional increase that will be added on for the services. I will tell you, looking at the rate study, we are trying to get that done as expeditiously as possible, but making sure that we take the amount of time that's required for it to be, a thorough and sound validation, that most providers are looking at no less than a 60 percent increase in rates. If not, there are several providers that are looking at over 100% increase in rates based on what we've seen so far.
You said you got one question? What's gonna happen? What's gonna happen after 2024? When after all the PDS, oh, the FMAP money run out? What's gonna happen to the rates when after? What's gonna happen to the rates if you use it? To raise pay right now? The money's supposed to run out in 2024. What's gonna happen to the raise then? When all the money run out?
So Arthur, right now, these increases are temporary pending the outcome of that rate study. Once the rate study is completed and the rates are raised according to what that rate study finds, they will become the permanent rates. They will not be, they will not, the raising of them is not dependent on those funds and that, that period of time we have to spend them. They will become what is the new, they will be sent to CMS and will become what is the rates for those services going forward.
That is good.
Did that answer all your questions, Arthur? Okay.
Yeah, Arthur, go ahead and send me what you have written and I'll make sure that we include that as part of our notes or part of the minutes. And Pam, thanks for your work on this.
Thank you.
That sounds like some substantial rate increases, so.
It is based on what we're seeing so far, and we're very happy with the participation that we had in the survey. This time was much better than the first time around. And so I'm very excited about where we're going with the rates. And so, Emily, I have to drop for another meeting. If anything else comes up that you need me, I know that there's several people still from Medicaid that are on, but you can email me if there's anything else that comes up that you need me.
That's great. Thank you.
All right. Thank you.
You got one more comment? Everyone needs to read. Your background? Oh, your background 4-page document. You said thank you.
Thank you, Arthur, for sharing that today. And I think you're right that we need to continue moving as fast as possible on this. So let's see. The next item on our agenda is general discussion. So this is kind of a new section. I don't know if y'all noticed that agenda has changed a little bit in like the formatting and order of things. Erin had sent out a template for us to use. So that's why it looks a little different this time. And I forgot to mention that at the beginning of the meeting. So under general discussion, we can bring up any other items that people want to. So I just have kind of a catch-all there. And one of the things that I wanted to get an update from MCOs on specifically is vaccination rates, both COVID-19 and routine childhood vaccines, and how many members are fully up to date. But are there any other items that people want to bring up before we move into those updates? Okay. I see Miranda shaking her head. Anybody else? All right. Thanks, Christine. Okay. So I can't get a good sense of how many MCOs are on, but if you all just want to share some updates with us, that would be great.
Anybody from WellCare on? Let's go backwards today.
Yes, this is Stuart on with WellCare. Can you hear me?
Yes.
My video is not working,
sir.
unfortunately. I've got a PowerPoint, my video is not working. So as far as COVID, we've got it under 18, we're at just under 10% are fully vaccinated. And as far as had at least, which is 17, almost 18,000 members. And then as far as had at least one dose, it's over 11%, which is 21,000 and change. If you look at over 18, we're at 38% are fully vaccinated, and at least one dose, 48%. And I've got a graph, actually I might be able to share it. I think my video, nope, okay.
Stuart, do you want me to try? This is
Well,
Paula.
well, it says disabled.
I just made you a co-host.
Oh,
so you
okay.
can try now.
All right, let me see. Can y'all see a graph, COVID vax? No?
I saw the screen change for a minute and then it went back.
Okay.
I forgot to stop sharing, Stuart. I'm sorry.
That's all right. Well, I mean, I'll just tell you. So basically, it peaked in August and September of last year. I mean, it shot way up for under 18. We got like a monthly look starting at August of 20. Of course, the vaccines weren't approved back then for children, but then it shot all the way up to almost 3,800 in August. And I mean, big spike. And then it drops in October to about 800, and then went up again in November, which is, fall, people got flu, getting shots, went up to about 2,100. And then it dropped until kind of steadily until February. And then it's just way down, way low since February, and has stayed down. And I've talked to our member services director, marketing director, and he told me this is the biggest marketing challenge he has ever faced. We have done a lot of things. We've even had last year, we will send a nurse to your house. You can get vaccinated on your couch. Very disappointing. And all the MCOs, we've got incentives. And one thing we've learned is that he told me whatever reward we give has to be immediate. You got to get it right now. It can't be wait 2 weeks, wait 3 weeks or whatever. And I think our most successful, and all the MCOs, we had a vaccination area at the state fair last August, and we got almost 1,000 people vaccinated. It's because right then and there, you had free admission to the rides at the fair, and you got a Walmart gift card. And, of course, you had the nurses right there. But I mean, that was the most successful. But I mean, we had, all of us MCOs, we had, free trips to Disney World and just stuff like that. I mean, it was disappointing. So, yeah, I mean, it remains, obviously it seems like people kind of made up their mind, especially, as we go on this year. Of course, we're getting into summer as well, but the vaccination rate, especially for children, is very much dropped. Of course, we've got, the new FDA approval for under 5. So, hopefully there'll be a surge related to that anyway, but it's been very disappointing.
Yeah, I don't think that's unique, unfortunately, to WellCare. Have you seen a similar drop in routine, or not a drop, I suppose, since you only have basically 1 year data on COVID vaccines, but are you seeing a change in routine childhood vaccinations as well?
What's really strange, Emily, and I just noticed this. I had the slides presented because I looked at our wellness visits, and our wellness visits actually increased last year, 2021, but the immunizations for children dropped in 2021. So more kids than the prior year were going to get their well visit, but they weren't getting immunizations. So, I mean, it definitely seemed, I'm just guessing it's that COVID vax fear that's spreading over into vaccinations in general.
Yeah,
That,
that's what we've been afraid of. And
Yeah.
you've seen a consistent drop, not a change.
I mean, it's not huge, but it's so odd. I mean, the wellness visits went up 5%, and yet the vaccinations dropped like, I think 1 or 2%. Like overall, the other immunizations dropped 1 or 2%, which is just like, more of them are going to get their wellness visit, but they're not getting the shot while they're there. And I just noticed it before the late this morning, and I haven't talked to our quality team. And we do all kinds. We got a quality team that's doing everything they can. A lot of looking at gaps and everything, especially with children, and trying to of course work with providers and everything. And we've got provider. I think all the MCOs do. We've got a $40 provider incentive, for COVID anyway. And then we still have all the other COVID incentives, but overall, I mean, it definitely. I mean, the only thing I can guess is just that COVID vaccination fear is spreading into vaccinations in general. I mean, not like I say, not huge, but obviously it's puzzling. How could the wellness visits go up and fewer children are getting immunized?
Going in the wrong direction.
Yeah.
Okay. Well, thank you for those updates. That's really helpful. It's also really nice to know what has worked, even if it's only been somewhat successful. But having like incentives immediately, that sort of thing, that's good information.
Yeah. Yeah.
Is anyone on from United?
Hey, good afternoon. It's Ashley Hobbs with United. Hey, Emily. So looking at the latest report we have, now this is 12 plus, and I only have it by one vaccine on this report, but United is sitting at 43.92% of our membership that are vaccinated with at least one shot with COVID. We do still have our $100 gift card. That's for 5 plus. That has been extended to the end of the year. And then we have the 14 free home delivered meals that's extended through the end of Q2, and that's for 5 plus as well. As far as the childhood immunizations, I will have to confirm with their quality. I don't have those numbers, but I will make sure to send those over to you.
Yeah, that would be great, actually. Thank you. If we could basically know the same, as what Stuart just shared, what the wellness visits looked like last year compared to routine immunization rates, I think that would be really helpful.
Yep,
and
I will follow up.
If you can get that fully vaccinated versus one dose, that would be great too. But this is good information. Thank you. So your incentives are continuing through the year, you said?
The COVID gift card is through the end of the year. Yep.
Passport?
Hi, this is Nicole. I'm waiting for a report to come that's updated. So if you want to go to someone else, then hopefully I'll be ready.
Humana?
Hi, this is Kathy Stevens with Humana. Excuse my voice. I'm recovering from some bronchitis. Our COVID vaccines for children from ages 5 to 11, we're at 10% vaccination rate, which is for us around 2,200 kids. For ages 12 to 15, we're at 26%, which is around 2,800. And then for 16 to 20, we're at 33%, which is around 3,700 there, 3,646. As far as 12 and older, our vaccination rate is at 47% at this time. On the children's vaccines, it's much like WellCare shared. We're not seeing an increase, actually seeing we didn't see the jump that we thought we would this year. I think everybody was anticipating more of a jump this year over last year and over 2020. And we too are not sitting that. And I can send a more detailed report over to Erin, and so she can share all of it's has quite a bit on it, but we can share that. I didn't include the wellness visits in it, but I can add that information and get it over to Erin as well.
Yeah, that would be really helpful, because I think we all have heard that, visits in 2020 went down, as with immunization rates, just because people weren't going to the doctor. So what it sounds like is in 2021, that sort of decline just continued. Maybe it was flatline, but it didn't improve. Is that what you're
I
saying?
agree. I think that wellness visit, that was an interesting item to add. So I'll get that added in the information and I'll send it over to, excuse me, over to Erin.
Thanks.
Anthem.
Hey, Emily, this is Sean Collins, the Chief of Staff for Anthem Medicaid. How are you?
Hi, thanks for joining us, Sean. I'm good.
I was going to try to share, but I don't think I can, so I'll just speak to it. Currently, for our COVID vaccinations, our 5 to 11-year-olds are running around 6%. Our 12 to 15-year-olds are at 21%. 16 to 17-year-olds are 29. 18 to 29-year-olds is 35%. 30 to 39 is 38%. 40 to 49 is 42%. And 50 to 64 is 52%. We're at 35.6% of our total membership with Anthem, of the 172,000 members that we have currently. We do have much like Stewart, we do have a $100 incentive. We've got some provider incentives as well that have been that we implemented back in Q3 and Q4. Those are still active. We've had about 5,000 redemptions of the $100 cards for those as well. In regards to what we're seeing, we are starting to see a pretty good decline on the COVID vaccination rates. We're still pressing hard to get folks vaccinated, specifically in the southeastern counties where we're struggling the most. So we've done a number of pilot projects in those specific counties to strategically go after those areas where we have low COVID numbers. In regards to the childhood immunization numbers, we have about 19.2% on the adolescent immunizations and about 21% on the childhood under 5. But like others have stated, I think what is occurring is immunizations have probably garnered a rough name because of, if I don't want to do the COVID vaccination, all of a sudden I don't want to do any vaccination. So we're struggling, I think, a little bit in regards to the perception. But we're working on a number of initiatives, specifically around HPV. That's one of our strategic goals this year. We think the HPV vaccination has probably garnered a bad perception historically. So we're trying to re-educate our member base around that particular vaccination series, that it's more of a cancer fighting vaccination than anything. So, we're trucking ahead here and trying to get the good work done, but that's kind of where we sit right now.
Thanks, Sean.
And as part of our outreach efforts, we are working on a back to school initiative where we're trying to bring the immunizations to these locations and help really drive education on the need for vaccines among children, especially like he had mentioned, the HPV vaccine, and then looking into our vaccine incentive around HPV and trying to improve that to make it more appealing to our membership, but also just having health educators out in the field to really focus on engaging activities to break down the stigma around vaccines and immunizations.
That's good to know. If anything seems to be working, please share that with us at some point during one of these meetings.
Etna. Do we have anyone from Aetna? Nicole with Passport, are you ready?
Well, I do not have the numbers that I was looking for that I was trying to obtain, but we do know that we've had about 1,850 folks who have requested the incentive this year in 2022. So I can definitely send you a more detailed report. I was emailing trying to get some numbers right away. We, have been like the others, just doing all the things to get folks vaccinated. Also, doing vaccination events with KHP and helping them. We gave out, I think it was like $90,000 in incentives to organizations who were doing vaccines. And so that's one of the things that we've been doing. And I think that was like 20 vaccine events. So like everyone else, just working really hard, but I don't have an exact number, but happy to send that to you.
That would be great. Thank you.
Yeah.
All right. Well, we appreciate those updates. And yeah, any additional information that you have to share, we are always welcome it. I think that takes us to the end of our agenda, and we can move on to recommendations. There are a lot of things that it seems like that we've recommended, over the past many meetings that are kind of in the works right now. So we really appreciate that, or decisions that have recently been made, especially covering legally residing pregnant people. So that's really exciting news, and we appreciate DMS's work on some of those things. I don't have any particular recommendations that come to my mind at the moment. Do any other TAC members?
Man, he asked about something.
Yes.
When do you think? When do you think we're gonna start meeting in person?
So that's actually something that we talked about at the last meeting, probably discussing today. So I'm glad you reminded me. We can consider going back to in-person meetings. I believe that DMS now has a setup, which Aaron is now demonstrating for us. So that would be a meeting room that we could, get around the table. And I believe we could do a hybrid setup with that meeting room. Is that right, Aaron?
Yes, ma'am.
Okay.
I turned the camera on so you guys could get a general idea of what the space would look like in the commissioners conference room where we typically meet. If it's going to be murals board's a little smaller. I think I can't see. We have 28 today. So we would still be offering the hybrid, I think, as long as that is still allowable. And Ms. Cecil, if I'm incorrect on something, please correct me. So I think we're still able to offer the hybrid. For the most part, everyone has elected to stay Zoom if possible. A lot of other members have to travel. The MAC has decided to maybe try to meet once a year in person, as long as they're still allowed to do Zooms. And so I saw Ms. Cecil popped on, so if she has anything to add, I'm going to let her hop in and add.
Thank you, Erin. We fully support a hybrid approach. We've been just wonderfully surprised by how much our participation has grown in all of our TACs and definitely the MAC. And I think that's a wonderful, if there's anything to come out of the pandemic, a wonderful outcome is getting more people engaged in what we do. It always benefits our program. As Erin mentioned, the room we have here, I think, could accommodate this TAC okay. We still remain a little hesitant, just to be candid, we watch the numbers and see them grow, and And, you know, we hear every day somebody has COVID, and so that continues, you know, to concern us, and certainly, you know, creating an atmosphere where that could be spread is of concern, but we understand the desire to get back in person. And, but I did want to emphasize, we will, I think, always moving forward, have a hybrid opportunity, because we don't want to lose that engagement.
I think that makes a lot of sense. And I agree with you that we're not quite out of the COVID woods yet. What do other TAC members think about having a hybrid option, and when would you want that to start?
I like the hybrid option. It does make it easier to attend the meetings and convenient, and I'm doing caregiving, so I can still do it and participate.
I agree. I think, you know, there are times when schedules make it difficult to get to Frankfurt, so hybrid meetings, and or like if one of us is sick, hybrid meetings do make it a lot easier.
Wait, yeah, I agree with all of those reasons. Would anyone like to have a goal of all getting together once a year at some point, so that we can just, you know, have time to, I think, get to know each other a little bit better? I think that's what the MAC was trying to do with their once a year sort of annual meeting, where the expectation would be, I think most people, unless you were being extra cautious or maybe had some other conflict, most people would be, you know, planning to come in person. Arthur, you cut out on us a little bit. Could you repeat that?
Motion.
Yeah. A motion to have hybrid meetings? Is that what you're? Did Arthur just disappear? Or is that just me?
I don't see him anywhere anymore.
Yeah, I think his connection wasn't very good.
I think he fell off. I don't see him, Emily.
Well, I'll just share that, you know, August 16th and August 18th or October 18th are our next two meeting dates. And I would probably need to do those hybrid. And then, of course, you know, maybe weather dependent. December would probably work for me. Arthur's back with us.
He was asking if y'all wanted to make a motion.
Arthur, would the motion be to have hybrid meetings? Yeah. It sounded like everybody was in agreement with the motion for hybrid meetings. So Arthur, can I count you as the motion to have meetings?
And we would in person. In person at least once a year.
In person once a year.
Suggestion to maybe do the once a year in better weather time period. You know,
Not December. Yeah.
April or May.
Okay. So our goal could be for 2023 to have an in-person meeting in the spring.
Yes.
Okay. I think that's a good idea. And the motion, Arthur, would be for the consumer TAC to have a hybrid meeting option and meet once a year in person.
No. He said he makes that motion.
Okay, thank you. Can I get a second?
I'll second it.
Thank you. All in favor, say aye.
Aye.
Any opposed? Okay, motion carries.
Emily, I did want to let you know, I've let some of the other TAC members know and some of the other boards, if you find yourself in Frankfurt, and you know you're going to be here and you want to join me in the conference room for a meeting or two, if you can just let me know a couple days ahead of time so I can let the security desk know that we're going to have guests. That is always an option. There was another TAC who had a member who was going to be in town in Frankfurt and was going to have a hard time trying to get to their meeting. And so that is always an option. If you find yourself in town, you need a place to come join the meeting, just let me know a few days ahead of time.
Okay.
Until I all by myself, so I welcome the company.
That's good to know. Thank you. And I don't know if Lee has already dropped off, but we've really appreciated all you've contributed to these meetings over the years, and sorry that this is your last one, but well-deserved retirement. So
Yes, we are quite sad.
yeah, if Lee's already gone, please just extend our wishes.
We will. Thank you.
Anything else before we adjourn? You can see our meeting schedule. All right, and do I take a motion to adjourn? I think I ask this every time.
I think we sometimes do, just in case. I motion to adjourn.
Thank you, Miranda.
I'll
I
second it.
it. Christine seconds. Thank you. All in favor?
Aye.
Any opposed? Motion carries. All right, everybody. Thank you very much for your time today. We'll see you in a couple months.
Good job, Emily.
Thanks. Bye.
Have a good afternoon, guys.